Thank you all for coming here today. I'm very pleased to introduce Mr. Alan Charles Geller, who's the senior lecturer from the Harvard T.H. Chan School of Public Health, and he will be speaking about actions taken by the MTA Environmental Health and Safety Advisory Group and presenting on the topic of mitigating the effects of COVID-19 in children. The struggle continues. So, Mr. Geller, I'll turn the floor over to you and thank you for presenting to our group.
Sure. Delighted to be with everybody. I'm honored to be with the whole group, and it's great to see some old friends and some of my new friends that I've met during this whole COVID pandemic. So a shout out to Debbie Sokolar and to Christine and to Dr. Regina Larac, who are with us today, as well as everybody else. So I want to just thank our dean at Harvard School of Public Health for providing funding for me to be able to do work over the last 2 or 3 years on all this. And I'm going to be concentrating mostly around kids. It is somewhat Massachusetts focused, but I think we can draw lessons from Massachusetts to apply elsewhere. And if anybody has any questions at the end, I'd be delighted to field them. And if you have questions for me afterwards or things come up, you have my email address. I will promise to respond to you. So here's what the basic outline. I'll give you some background data, which probably most of you are familiar with. I think I'm going to be concentrating most on what do we have left for protection. I have a number of slides around that, but there's really not too much. I'll spend a little bit of time looking at some hallmarks of public health interventions in this work, and then try and do some speculations of how the pandemic's going to play out in the next few months and end it with questions for consideration. So just to catch us all up with the data, I know it's a little slippery, but I think we can safely say that the estimates, of course, which are based almost exclusively on PCR testing, is that we see about 50 to 80,000 cases in the United States per day. And I think conservatively, we can estimate that the real numbers are close to 5 to 7 times greater. So if you want to take the outer bound of that, we're probably talking still at least 500,000 cases per day in the United States. If we look at the test positivity rates, they're about 9%, which is high. It's really high. It's about the third highest they've been in a while. And we can see a connection if you look at the COVID data tracker in the United States, that states that have the highest test positivity rates, generally over 10%, are the states that have the highest hospitalization rates. So we're talking about 25,000 people hospitalized in the United States per day, and about 3,000 or 4,000 out of those 25,000 are ICU patients. And we just have not been able to budge down the number of deaths estimated per day between 350 and 400. A couple of weeks ago, it was over 400. So if we do the math, we come up with a tragic number of 400 times 365, which is well over 120 or 130,000 deaths per year, as we would project, which is just obviously tragic and totally unacceptable. If we look at the effect on kids, I remember having these discussions with Dr. Larac a couple of years ago when the naysayers were telling us that, kids don't get COVID. And we've obviously seen data which completely belies that. They get it, they get serious cases, they pass it along to parents and grandparents. And we know this is just a few months old. You can see here the total number of COVID cases. And again, these are really low counts because my guess is that the ratio of home antigen testing to PCR testing is probably greatest in the young people's population. We can see that the latest estimate from the American Academy of Pediatrics says that almost 15 million children are reported to have been tested positive for COVID since the onset of the pandemic. And just to get a sense of this with the effect of Omicron, I can argue here that just about half of all cases reported in the United States since the pandemic began have occurred in 2022, and we're obviously still not all the way there, completing or finishing 2022. So Dr. Kavanaugh was talking about the other variants. We just don't have a really good sense of the numbers here because clearly genomic surveillance is not universal across the country. The sampling is pretty low. I think we safely say, as of whatever today's day is, that BA5 accounts for 70% plus of all infections in the United States and started, I think back in June of 2022, when it accounted for 13% of all infections, and that was 6 months after it was first acknowledged or identified, in South Africa. So we have new variants. We know about the power of immune escape. We know about enhanced transmissibility. One thing that, of course, that we try and talk about all the time is that maybe in a positive way, the more people who can be vaccinated, the lower the chance of transmissibility, or conversely, the less inclination for vaccination is the recipe for far more cases. I mentioned earlier, there has not been a marked increase in hospitalizations and deaths, but some of the projections are telling us that in the Northeast, we're beginning to see an uptick of this, and particularly hospitalizations, with probably more hospitalizations in the near future if we see this uptick as we're seeing in the test positivity rate. So you're probably all familiar with this wonderful Swiss cheese model that many people have used. The concept of multiple interventions at various levels often work best. While I'm probably going to concentrate too much on vaccination and not talk enough as much as I should about multiple layers, let's really try and think of this conceptually as multiple layers, and we divide this into sort of personal responsibilities and shared responsibilities. And if we were to update this Swiss cheese model you see on the lower right, vaccines, we should probably be talking about therapeutics and talk about Evishield and Paxlovid. And those are stories unto themselves because they're way too underutilized at this point. So let's think about how many levels do we have left. So we clearly, and we'll talk about that, have plenty of room for improvement with vaccine uptake. We've lost masks in schools and most all indoor settings. But do we have to revisit this? And I'm going to make a point a couple of times that when the schools are the great, probably one of the strongest reservoirs for transmission of COVID, and we clearly have to get off the dime and say that when we do have surges, we have to be able to consider reinstituting some kinds of mask mandates in schools, and I'll talk about some language around that. We would all agree that PCR testing is underutilized. Rapid antigen testing, sometimes we be careful what we wish for, and obviously there's tremendous pluses of rapid antigen testing, but the unintended consequences of rapid antigen testing is that we've lost any and all ability to be able to track how many positive cases we have. If we had a chance to do this all over again, we would have tried to figure out a way to be able to connect rapid antigen testing through some kind of technology to departments of public health so that we could have some monitoring of this. We've seen snapshots of work that nurses in Massachusetts have done to encourage parents to report rapid antigen testing. And that, for the first time, led to some real good grasp of numbers in Massachusetts, which then told us that at least 40% of school children in Massachusetts in the last school year had COVID, and 60% of teachers. Contact tracing and social distancing are words that are obsolete. And we obviously have had no organized audit of school buildings and public buildings. Dr. Kavanaugh mentioned the Massachusetts Teachers Association and the Environmental Health and Safety Committee, which has really tried to make an extra strong effort to see if we can at least do that so that we know building by building, classroom by classroom, how many air exchanges we have per hour. And if we can't make a solution-oriented plan until we know the damage and the effect of poor ventilation. Most recently, as of last week, there was a White House conference on indoor air ventilation, and people can look that up. There was a little discussion about it in schools. So vaccination rates, if we look at this by 2 shots, and again, there's been some controversy because CDC is only acknowledging 2 shots as their criteria, as opposed to really looking at one being truly protected by additional vaccines. So this is where we stand in the United States at this point. You can see that among 5 to 11-year-olds, the vaccination rate across the country is 31%. It's obviously lower for people under the age of 5, doubles to age 12 to 17. And in Massachusetts, we actually have a pretty good story that about 80 to 85% of 12 to 17-year-olds have been vaccinated, but definitely lower numbers for 5 to 11s and lower numbers for kids 0 to 4. And you can see a step increase as you age. So that's why in some ways, when we look at the total vaccination rate for the United States, it's a bit deceptive. I think we'd all agree that it makes some sense to try and look at this age group specific. And we can all, by looking at this, see where we have some really profound gaps that we have to make up. So this has been a little bit repetitive here, but I think we all know this in terms of the percentage of the eligible population. You know that less than half of those eligible have gotten a first booster dose. And as I think Dr. Kavanaugh mentioned, it's definitely much less for the second booster dose. And the point that was just made that across the United States now, it looks to be about 7% of people in the United States have had the bivalent booster. And in Massachusetts, which is now reporting it by age group, we see that even among people 75 and above, it's only 11%. So we've got a long way to go to improvement. And we know, obviously, the great benefit of being vaccinated compared to unvaccinated, with just whopping differences between the two. And still, the great majority of deaths are in unvaccinated individuals. This might be hard to see, but the point that I want to be able to make is the effective vaccines in real time. So we looked at the change in the ratio of Massachusetts cases and deaths by increase in vaccination exposure. And we can see in the beginning of the pandemic, before vaccinations, there was actually one death for every 25 cases, which is, again, just something just shocking to think about. And with each month or each series of months and group times, we began to see, as the population became more and more vaccinated, that ratio of cases to deaths, of course, expanded about tenfold. So that if we look at that period from November of 2021 to the end of January 2022, we see that that went up to 265 cases per death. So at least a tenfold improvement as our state became better and better vaccinated. And we can update that, and I would imagine that that would show even more improvement. So where are we at with vaccination facts in Massachusetts? And again, anything that I report here has problems in Massachusetts, but they're going to be even stronger across the country. We've talked a lot, we've tried to write some articles in the Boston Globe with the common refrain that Massachusetts is a tale of two states. So in Massachusetts, we know this by communities because we know how many communities we have. We know what the vaccination rate is per each community. And we can see here that in a little bit more than half of our communities, fewer than half of our children ages 5 to 11 are fully vaccinated. This is driven a lot by race, by ethnicity, by rurality, and a lot so by partisan politics. We know that in 2020, President Trump won 40 of the 351 communities, and in every one of those communities, they fit into this group of fewer than 50% of their children have been vaccinated. So partisanship plays a very important role. Only 17% of children ages 6 months to 4 years of age have been vaccinated. And again, some of our most hard hit cities that have been really walloped by COVID, as we all know, have the lowest vaccination rates. And not only do we have massive inequities in terms of where you live in Massachusetts as to who's vaccinated, but we've been stuck in place. I know that this only takes us through the end of April, but it really doesn't matter, because if we look at the blue line here of at least one dose or being doubly vaccinated, these numbers have not changed really much since April. So in Massachusetts, as in the rest of the country, November 2021, the vaccinations became available to kids 5 to 11. About a third of the state jumped through fire that first week or that first month. After the original flurry of activity, we've been stuck here since about February. And so now, even in October, we've only had 3,000 or 4,000 more children ages 5 to 11 who've become fully vaccinated. So those are the two messages there: massive inequities, and the vaccination rate for our children 5 to 11 is flat as a pancake for many, many months. And so we had the opportunity to work with a pollster in Massachusetts who received some funding. And I also want to thank Dr. LaRocque, because she's gone to bat for us. We're going to do a much more expansive survey here. But Steve Cozzella, who's the president of Mass Inc., a large polling firm, has looked at inequities in vaccination rates by surveying Massachusetts parents. And we can see here the point that I was raising before about rural areas and gateway cities having lower vaccination rates, and lower vaccination rates among Black families with lower income and Latino families with lower income. And these are things that really need to be addressed. One of the things that we want to look at. So what we've been very interested in is trying to learn as much as possible. And in future surveys, we want to learn even more. And I could just ask you to fix your eyes on the third row. So what this is saying is that among parents who have been vaccinated and boosted, there's a very high proportion of their children who've also been vaccinated. But we have plenty of room for improvement among parents who've been vaccinated but not boosted. And if we look at that 39%, 39% of them report that none of my children are vaccinated. And lots of us talk about a family approach. Now, how do we get family members in, many of whom have received their primary series of vaccinations, but to be able to come in for boosters and at the same time to ensure that their children are vaccinated? We still think that there's large issues in Massachusetts around access. We've closed mass vaccination sites. I know that Dr. LaRocque has had a lot of success with mobile vaccination. That's a great idea, but it needs to be deployed far more substantially across the state. We definitely see school buildings as being really important. This is work that Christine has done, really trying to work with the MTA on opening up school buildings. And we think by really trying to make a strong push to promote vaccinations well ahead of the time when these school doors can be opened is still a key part of our toolkit and toolbox. So again, that's a key figure there, that 39% of times when the parent has been vaccinated and not boosted, but their children have not been vaccinated. So the same survey that Steve Koczela conducted, we tried to look at what have been some of the main reasons for lack of vaccination. Among those who do not plan to vaccinate their children, what are the common reasons? And we're still stuck on this question of safety concerns. And we really need to try and figure what's behind that. Is it primarily still short-term side effects that parents are concerned about? Has the myocarditis argument gone out there and has it been rebutted well enough? Is it primarily long-term effects? And one of the things that's so puzzling is the point that I raised earlier, is the doubly high rates of vaccination among children 12 to 17 compared to 5 to 11. So what's the perception of a number of parents of older children that they're willing to get those kids vaccinated, but how things really fall off the vines, if you will, for their younger children 5 to 11. So exploring that would be really important. So we look at safety concerns, we look at age, as I mentioned, and still lots of questions around trust. And one of the big issues that we would argue for many of us who saw the great ads in Massachusetts and ads that people have seen across the country around the importance of tobacco cessation and the really clever graphic ads that led to a massive decrease in smoking use, we need to be able to deploy those same kinds of really well done, probably expensive vaccination campaigns coupled with much more improved access to see if we can continue to bump up these rates and not just assume now that the rates are not going to increase. So I always like to try and think of practical ways to improve rate of pediatric vaccines, see what people think about this. And when we have a conversation in a few minutes, you can let me know what you think about this. We found out through talking with people in the Department of Public Health in Massachusetts that only 50% of pediatricians in the state have ordered the COVID vaccine for people 5 to 11. I'm flabbergasted by that. And one of the issues is that COVID has really taken lots of nurses out of pediatric offices. Lots of pediatricians will tell us that they need to figure out a way to get single vials for vaccinating their youngest kids. Now it's 10 doses per vial, and pediatricians and family physicians are concerned about wastage. So that's one key issue. We want to be able to survey local pediatricians and really try and understand that more deeply, why it's only 50%. We've been hoping, but it doesn't look like it's actually come through, that new publicity for vaccinating kids under 5 would bring in families who have not vaccinated children 5 to 11. We haven't seen that. So again, to try and make that big push that parents do have lots of trust in the district, in the school building, and how can we energize district superintendents, community liaisons, teachers in this effort to really try and vaccinate kids in the fall. So there has been some effort at the state level. As of late June 2022, the Massachusetts Vaccine Equity Initiative was awarded $7 million in grants to support organizations, and they've taken a position that the 20 hardest hit cities are where we need to go, and they've tried to bolster those community organizations by giving them funding. I think it's a really important effort. They tend to be larger cities, but as you may remember, I showed you a slide to show that there's 182 cities in Massachusetts that are vaccine deficient, if you will. So we really need a statewide plan, a statewide campaign to be able to address this for our children 5 to 11 and children younger than that. So what have been some good efforts to improve vaccinations? There have not been ones, to the best of my knowledge, that I've seen in the peer review literature to do so in the pediatric population, but I think in the next slide I can point you in the direction of some ones to consider. So many of you may have heard of the work in Chelsea, Massachusetts, which has really been an ideal setting, particularly in the adult population, but they've also done a remarkable job with older teens. They're one of those 72 organizations that have received state funding, and they've taken the position, and Dr. LaRock can talk about this after I'm done, which isn't necessarily making vaccine front and center. And I think it's a great idea. They've provided wraparound services door to door with people going and asking questions. Do you need information on jobs, computer classes, food, English lessons, housing, vaccine? Maybe not in that order, but it's not doing it just, knocking on doors and asking people exclusively around vaccinations. And these wraparound services were very important at the beginning of the pandemic as well. A lot of this work arises out of community health centers and also the work of Mass General. And a lot of the work that they've had to do is that double whammy, what Dr. Kavanaugh was talking about before, countering misinformation and figuring out at all times how to boost access through mobile vaccination programs and the like. So this has been a really nice model, and one that would be wonderful if it could be replicated, not just in Massachusetts, but across the country. Now, something in the peer review literature, which was a great piece, this is one that I shared with my students who I teach a public health class. This is a community-based vaccine initiative in the Mission District in San Francisco. And this is a community-led, community-inspired program. You can see the large number of vaccinations that took place over the 16-week period with clearly a multi-layered, multicultural input. Here's the citation for it. And in the next slide, I can show you their 3-point plan. And again, if we think about this in the school setting, we can't just open up a school door on a Tuesday and say, okay, let's everybody get vaccinated. What the lesson of this is, pre-vaccination is so important. You can see that in blue, motivate. So undertake community mobilization and try and really generate a demand generation activities. Then the vaccination program itself, a low barrier, client-centered, community-based initiative. And step 3, this is all work synergistically, is the importance of those people who've been vaccinated to spread the word. I mean, networking is incredibly important here. If there was a program to do this kinds of activation where one person who's vaccinated has a way to be able to speak with 2 or 3 of their friends to encourage them to be vaccinated if they've been sitting on the fence, it would be just a mammoth and really important effort. So again, thinking of that 3 steps, motivate, vaccinate, activate. I really like that model. So I'll just talk for just a minute about improvements in ventilation in schools. We still really have to do that survey in Massachusetts and nationally to understand room by room how many classrooms have the optimal goal of 6 air exchanges per hour. There's definitely been studies to show that 6 air exchanges per hour definitely leads to better health outcomes, reduce COVID. We also know that better ventilation is really important for cognition, for reducing school absences. And I'll show you a slide in a minute that just sort of blew me out. And I'd like to see what you think about this. But the Center for Green Schools has come up with where things are at. And it looks like most schools are not really subscribing to goals of placing or upgrading their HVAC systems. In Massachusetts, we know, as in many parts of the country, there is money from different federal agencies to provide to districts, and it's been one really strong concern as to where that money has gone. There is a move in Massachusetts. There's actually some legislation to support that now, to say that by December 31st, 2024, a random number of school buildings in Massachusetts have to be inspected for ventilation and filtration, and that those results have to be provided to the Department of Public Health. But goodness, waiting more than 2 years for something like that just seems nuts, when we can use something like CO2 monitors that cost $250, and that could be used by teachers, parents, to be able to do those kinds of inspections and auditing in their own school buildings. Home testing, as I mentioned, the unintended consequences, rapid testing, while it's been a great improvement, often what happens in these situations, as we all know, is that those communities with the greatest wealth are the ones who were able to put into place an important public health goal. And you can see here that if you look at the number of home tests purchased in the last 3 months, just follow it along the bottom column, you can see for people whose income is less than $25,000, that 46% of people said that no, they have not purchased any in the last 3 months, compared to 29% for people with greater income. No surprise, but if we're going to be thinking of rapid antigen testing still as a public health strategy, we have to deal with the question of the inequity at the bottom of it. So mask language matters. And we've talked about this lots, when the masks came off in Massachusetts on February 28th, 2022, a number of districts said, okay, well, we'll come up with some really good language, kind of cute language, optional or mask friendly, but it's clearly not enough. The next layer, the next level is some districts still hold on to recommend. And now I found out that there's a few districts in Massachusetts where they're beginning to talk with one another right here and now, because as they've had outbreaks in their schools, they've felt that the language or optional or mask friendly is just not strong enough. They realize that they can't mandate or require parents to have their kids be masked in school, that there'd be some resistance at the level of the school committee and to some irate parents. But they've had some success using language of we highly or strongly recommend. And in 2 districts where they've come forth with that, when there's a surge, there's been quite high compliance, at least in the elementary grade. So I think this is part of a conversation that we really need to be having. That's why I called it Mask Language Matters. And there's parent support for mitigation measures. So we know that there's some people who get really irate and not necessarily storm their school committee meetings, although in some places they do, but make a lot of fuss. But underneath that, there's really strong support for providing rapid tests for families to take home. Part of the statewide survey of almost 1,500 residents, 86% of parents wanted it and probably still do, but districts are not doing it anymore. Regular testing, all kids at school, supported by more than 2/3 of parents. Requiring all students and staff to wear masks, more than half. I'm not sure what we'll see if we were to repeat this survey in October and November of 2022, but it counters the myth that parents are done with this, or that parents were done with this in April. They still very much were concerned about the effect of COVID in classrooms and in schools and among their children and family members. So what are the best metrics to be looking at to see what the COVID burden is? Well, the wonderful research team at the University of Massachusetts at Amherst has tried to look at wastewater testing, and they did so at the UMass Amherst campus amongst 37 dorms and school buildings. And it was a wonderful model. And during the whole period of time of the highest peak of COVID, only one person was hospitalized among hundreds of people who were infected. And so they used wastewater data and then made changes at the building level when they saw the levels of wastewater data being high. People have tried to do this now, thinking of this in Massachusetts. It failed because there was a concern that there's just not enough poop among children in school buildings to make it work. But we're going to continue through work with Christine and myself and others in MTA to continue to push for that. But one thing that we'd really like to do, and I'm really hot on the trail, is using school-based attendance records. as triggers for medical and public health review. And we can now monitor what we're calling health absenteeism due to COVID and other respiratory diseases. In the next slide, I'll show you what we're seeing. So this is Massachusetts attendance for kids grade K through 12, 2018-19 versus 21-22. So if you look at the top row, I think the most important thing that I'd ask you to look at is still these numbers are high, even 2018, 2019, that 34.5% of school children in the state of Massachusetts missed 10 plus days pre-pandemic. That's a story unto itself of how that can be improved. But we think that the great majority of the increase from 34.5% to 55.9% in 21-22 is attributed to COVID. So we're in the process of trying to gather attendance records for school districts in real time to see what they look like. And in the first couple of districts that we see, it's playing out where they look very, very similar to where things were in 21-22 as opposed to 2018-2019. So I think attendance data, while it's not perfect, we don't know for sure that it's going to be COVID related. We think it's a really good sentinel tracking system. And in fact, we can learn from the districts a ratio of the number of absences over the number of children to see if that ratio continues to increase. So I think what I'm going to do in the interest of time, since I think we probably have a very enlightened audience, and I want to make sure that I allow enough time for questions, maybe I'll just show this. I always like to have a little humor in these. A parent talking about on Twitter, and again, that question of rapid antigen tests. For the love of God, please stop repeating the lie that so far the US has not had a big surge from Omicron subvariants like we saw abroad. It's not that we aren't having a surge, it's that we aren't seeing the surge due to manipulated metrics and a shift to unreported home tests. So our next steps for schools, I'd love to get other people's ideas. Pushing again for the districts to promote vaccinating the large number of 5 to 11-year-olds still not vaccinated. In Massachusetts, we had a really good series of dashboards across the state. Maybe I'm still naive, but we'd love to be able to figure out ways that we can prompt districts to reinvigorate, to come back and try and bring those monitoring systems back so that they can track COVID. With DESE, that's the Department of Elementary and Secondary Education, unwilling to do this, we need to make provisions for rapid antigen tests being opt-out rather than opt-in. My point about strongly reconsider remasking in periods of surges, reviewing week-by-week attendance data to see what that looks like, and the point that I mentioned earlier about trying to get a portable CO2 monitor into every district in the state rapidly. There is money to buy those, and we need to be able to think of a way that we can resourcefully use those building by building. So just a few misconceptions, and I'm sure there's others, I'm just choosing these. The notion of reinfections are very rare. I think I heard Dr. Kavanaugh rebut this earlier. Before Omicron, reinfections were rare in New York. As a few weeks ago, at least 25% were reinfected. It's probably higher than that. Almost all shedding of the virus occurs within 5 days. Another study by the person Marquez, who I quoted about the community vaccination programs, has just written a paper in JAMA Network looking at this question and has shown that 80% of people in their clinics were still shedding virus after 5 days. So that question of 5 days as being the cap is poppycock. It just doesn't go along with reality. The rate of rebound on Paxlovid is high. While we hear reports about it, we saw that with President Biden, with the First Lady, when in fact we look at the most recent data from a preprint, we see that it's about 2.31% or 5.8% if we look at it by people with symptoms or without symptoms. And finally, most importantly, vaccines in the Omicron period provide very little protection against COVID. It's definitely one of the lines that the anti-vaccine people put forth, when in fact I think we all know that vaccines and boosters largely, not perfectly, but largely protect against hospitalization and death. So I'm a frustrated captionist or cartoonist who has no idea how to draw, but maybe just with a little humor in closing, a couple of little observations that I've sort of written down, thinking this was me, a man desperate for physical activity, but fearful of being outside in his crowded block of unmasked individuals walking by, shoots baskets from a second floor bedroom into the driveway hoop 1 floor below. And the last one is again personal. This was my little grandson last year, who was out with my wife and out for a walk with his grandmother, looking at flowers, points to a lovely one and says, "Look at the beautiful viruses." So I think when my little 4-year-old, who's now 5, is talking about this, we have to figure out a new way of combating this. So thank you very much for your time, and I look forward to entertaining questions and launching into a good discussion. Thank you.
Okay, well, thank you very much for your excellent presentation. I should add, I have a portable CO2 monitor myself.
Ah,
They're now under $150 on
Whoa.
Amazon.
good to
Oh,
know.
nice.
And it's interesting. Some of the areas have poor air quality that would surprise you, and others have better air quality when you thought they would be poor. And of course, this is just a minimal level of air quality. It's
Mhm.
not the exchanges that would be needed to decrease transmission of Omicron. But if you've got CO2 levels above 700 or 800, you're in a building that probably has inadequate ventilation.